Good morning, everyone. This is CHF, one of the second year internal medicine residents at Memorial Healthcare System in South Florida. I'm excited to present this case today of a pheochromocytoma presenting as acute congestive heart failure. Um, our patient was a 38-year-old female with a past medical history of poorly controlled hypertension and type 2 diabetes. She presented to the emergency department with palpitations, dyspnea, and signs of volume overload, as well as imaging and lab suggestive of CHF. All infective workup was negative. The initial echocardiogram showed an EF of 25% with multiple segmental abnormalities and global LV hypokinesis. She was started on diuretics, vasodilators, as well as GDMT as far as her blood pressure could tolerate. Cardiac catheterization ruled out atherosclerotic disease, but it did comment on mildly elevated filling pressures. She received an inpatient cardiac MRI which showed an EF of 32% with global hypokinesis and eccentric hypertrophy, favoring tachycardia-induced cardiomyopathy over hypertensive cardiomyopathy, which would have presented as a concentric LVH pattern. Despite aggressive diuresis for 4 days, all the meanwhile where she had great urine output, she developed acute worsening of her respiratory status on day 4. Repeat chest x-ray was concerning for possibility of flash pulmonary edema. She also continued to have tachycardia and poorly controlled labile blood pressure while being on 3 antihypertensives. Evaluation for secondary causes of refractory hypertension revealed elevated urine and serum metanephrines and norepinephrines as well as VMA. Interestingly, the ratio of metanephrines to norepinephrines was less than 1, which favored paragangliomas as the cause as per literature review. We did an adrenal CT. It showed a 3.8 centimeter right adrenal nodule, favoring pheochromocytoma. However, there was uncertainty regarding this catecholamine surge only coming from the adrenal nodule, most likely a pheochromocytoma, or a presence of paraganglioma as well, or both. We started alpha blockade with doxazosine. Carvedilol was weaned off, and limited GDMT with Entresto and spironolactone was continued. After 7 days of alpha blockade, we restarted her carvedilol at low doses and titrated up. Due to the uncertainty of diagnosis, we thought it best for her to get medically optimized outpatient as well as get a PET CT just to make sure that there was no paraganglioma involved. She did receive a PET CT outpatient. It confirmed only isolated uptake in the adrenal mass without any additional foci of uptake. Patient underwent successful laparoscopic right adrenalectomy soon. She was seen on an outpatient basis 3 months after the procedure, where she had great control of her blood pressure while being only on 1 antihypertensive, which was Entresto as part of her GDMT. In conclusion, we describe an unusual case of catecholamine secreting tumors presenting as frank CHF. There have been some studies in a retrospective analysis of 36 patients. The authors described only 3 patients who presented with overt left ventricular failure. However, the timeline was not really clear in this study as to whether this was on presentation or afterwards. The tricky part in this situation is identifying the source, especially if radiologic evidence and lab findings are not really aligning, as well as ensuring adequate alpha blockade with simultaneous maximal uptitration of GDMT, each representing unique challenges. Thank you very much for your time.